It basically leads to this inflammatory loop that we talked about, and again, characterized by itching, scratching, and then further damage to the skin.
Mm-hmm.
And also, those with eczema tend to have higher levels of Staph aureus on the skin surface. And we actually see when people get flares, their level of staph on the skin surface goes up in conjunction with that flare. So
Okay.
one thing that we really have to worry about as well when people have eczema is secondary infections. So when you're coming up with a plan for a patient, having that plan of like, hey, if you get an infection, this is what you're going to do. And this is what an infection looks like.
Welcome to the Advanced Women's Health Podcast, where we empower women with the latest insights and advice on holistic health. From cutting-edge medical research to practical wellness tips, our mission is to help you thrive at every stage of life. Join us as we explore topics ranging from hormonal balance and reproductive health to nutrition and mental well-being. Whether you're seeking solutions for a specific health concern or simply want to enhance your overall wellness, you're in the right place. Let's embark on this journey to better health together. This is the Advanced Women's Health Podcast.
Hello, everyone, and welcome back to today's episode with Dr. Dasha, where we are diving into all things eczema. We, in the next couple of episodes, are going to cover a variety of topics that we haven't covered that we treat a ton at Advanced Women's Health, and we're going to start with eczema. So let's dive in and talk about what feels like a very big term. It feels like everyone has been told at some point they have eczema, and really how you think through it, because we have these conversations internally all the time. Someone will send a picture with patient consent, like, what's this? And there's a gamut, but someone will say, is it eczema? So what even is that? Let's start there.
Totally. So eczema is usually used as this umbrella term for itchy, inflamed, irritated skin. So if you hear eczema, it is very vague, right? The most common one that kind of starts in childhood is what we see as atopic dermatitis. So this is a chronic inflammatory skin condition characterized by itch, red rashes, and dry skin. Typically, we call it that itch that rashes, and it usually becomes in childhood and kind of like wax and wanes over time. But when we're looking at this umbrella term, right, we can have many things on there. We can have any type of dermatitis, so contact dermatitis. We can have dishydrotic eczema, which is really annoying. It starts as itching and then kind of bubbles, form these little blisters, and then they pop, and it's very painful. And then we have chronic hand eczema, neurodermatitis, which is typically diagnosed as lichen simplex chronicus, so basically meaning that there's some factor, we don't know what it is. It's not like a contact dermatitis, but it's actually the nerve that is causing this hyperactive response. And we itch and itch and itch, and it almost causes like this thickened skin, and it continues to be itchy over time. And then we have discoid or nummular eczema, which is eczema that appears in these little disc shapes almost. And that, again, can be a chronic condition too. So what it is in general, it can be many things, but if we're talking about atopic dermatitis specifically, usually comes with allergies and asthma as well. So when we manage that, we have to manage a whole host of other symptoms too.
So let's break it down, because to me, I use medical terminology to kind of guide, right? So there seems to be two big categories. Anything that ends with itis, which is essentially inflammation, and dermatitis is just inflammation in the skin. So one origin seems to be skin-based, and then there's this kind of conversation about the like nerve piece of it. So is it fair to say that one of them has a bigger component of like the feeling of an itch and the nerve, and the other one has a component of something inflaming the skin? Like, if we were trying to put it in broad stroke categories, would that be accurate, or like how would you break that down further?
Yeah, I would say for the most part it is accurate, but anytime we do have an itch, there will be nerve involvement as well, right? Because let's say there is some sort of like contact dermatitis where you put on something that is irritating and maybe there's a little bit of skin barrier dysfunction to start with. you're basically the nerve sends a signal and says, hey, I'm itchy. And then we scratch, and it almost becomes this like loop of dysfunction that keeps flaring, right? So we have trigger, right? And then we have an itch. We get immune recruitment of mast cells, dendritic cells, things like that, big Th2 response. And then we also get more dysfunction in that sense too, because it's heightening that signal essentially.
Okay. So essentially, there is always a nerve involvement and there is some kind of trigger, whether that trigger is to the nerve or to the skin. And that then causes the immune system to come involved and worsen the itch sensation.
Yes.
Okay. And so with that, you said a couple of things like barrier disruption and like a trigger. So what are some examples of, well, let's start with barrier dysfunction actually. What is that? And then let's get into what some of those potential contact triggers could be.
Totally. So the simplest way to describe atopic dermatitis is, again, like we talked about, this combination of skin barrier dysfunction and immune overactivity. So kind of the biggest triggers for that, again, we don't really know why, if we're looking at atopic dermatitis, why it happens. We seem to think it's a combination of genetic and environmental factors. If we're looking at the environment, it can be anything from like environmental allergies. So you might notice that like when it's allergy season, there's more pollen in the air, you can have more flares. Anything topically, like even if it's quite soothing, it has the potential to cause some sort of irritation. Anything with fragrance causes a lot of irritation as well. So in all my patients, I ask, hey, what kind of laundry detergent are you using? What kind of moisturizer? What are you using in the shower? Because if there is some sort of fragrance there, that's oftentimes one of the biggest irritants. So,
And so when you say fragrance, do you mean like if you can smell something, then that's an irritant, or do we have to look for something on the label?
I would always look for something on the label because even if you can't smell something, then it doesn't mean that it's not going to have like no fragrance in it. You know, sometimes companies can put a fragrance in there that can mask any unwanted scents from some of the other ingredients to make it more neutral. At the end of the day, just turn the label around, see, is it unscented? Is it not? And if you do have eczema, it's really helpful for looking at the seal of approval that the Eczema Society gives.
Okay. So we have some kind of trigger, potentially environmental, chemicals, fragrances being one big one. But let's get into barrier dysfunction a little bit. I know we've talked about it in the past, but if I can put something on my skin and have no problem, and I put something on Aiden's skin who has eczema, right? What's the difference between those two things?
Totally. So I'm just smiling because you've heard me talk about this before, but there is one of the biggest risks for developing eczema. Again, family history of atopy. So if your family member has it, you're more likely to have it as well. And a mutation in the filaggrin gene, which is responsible. I knew you'd laugh as soon as I said it. And this gene,
No one here is talking about any beef tallow. It's a filaggrin gene that is absolutely the cause of dysfunction.
anyways, this mutation in the filaggrin gene, it is responsible for the maintenance of integrity of the skin barrier. So the filaggrin protein, it aggregates, so brings together keratin filaments, which are skin cells, and it has a role for maintaining this extracellular lipid or fat matrix. So basically, it is responsible for the structural and mechanical integrity and also helps maintain its water holding capacity, basically like our skin's moisture barrier, right? So that's a big one too. And any disruption to this can basically lead to any sort of irritants being able to get into the skin and kick off this reaction.
And so as soon as we have that disruption, something's the trigger. And now the body genetically or otherwise, because I'm sure we'll talk about the gut and everything, can't get back under control. So it's just this cycle that starts to spin and then they itch on top of that. And then now we have a systemic problem.
Exactly. It basically
Yeah.
leads to this inflammatory loop that we talked about, and again, characterized by itching, scratching, and then further damage to the skin.
Hmm.
And also, those with eczema tend to have higher levels of Staph aureus on the skin surface. And we actually see when people get flares, their level of staph on the skin surface goes up in kind of in conjunction with that flare. So
Okay.
one thing that we really have to worry about as well when people have eczema is secondary infections. So when you're coming up with a plan for a patient, having that plan of like, hey, if you get an infection, this is what you're going to do. And this is what an infection looks like.
Hmm. So outside of filaggrin, what are some of the other causes? Because I'm assuming not everyone with eczema has been shown to have this genetic mutation. So what other things could contribute to that barrier? Not holding moisture, not having the fat content, not being able to be in integrity.
Yeah, so like we talked about, allergies are a common trigger, any sort of irritant to the skin. So if you're working with, I'll see this a lot with my patients with chronic hand eczema, but basically if they're working with a lot of like chemicals and things like
Hmm.
that, or if someone's like washing your hands is obviously great, but you do have to replete the moisture after you strip it off. And we see this a lot when people like healthcare workers also that use a lot of alcohol-based hand sanitizers and things like that.
Hmm.
Emotional stress is also a really big trigger, so some people won't even notice. They'll also like pick at their skin,
Hmm.
so that's a big one. Extreme temperatures, humidity. So those can all kick off that sort of cycle again in terms of
Hmm.
like the barrier being weakened and then we get inflammation. So again, it's this like big kickoff of things. But I would say the biggest one, like after the predisposition, is the environmental piece when people like are where the skin barrier is damaged and you get the opportunity to let irritants in.
Hmm. And I think that's in dealing with eczema so much over the course of practice history. Even again, like I said, my youngest has eczema. It is one of those things that it can feel completely under control, and then it's one trigger, and all of a sudden you see these flares show up. So one of the things that I think is really interesting is why the flares show up in the specific places they do. So when we are looking at eczema, like why is there characteristic patterns for where it shows up? Because it's interesting. It always tends to be in similar tissues, similar areas when those flares really do bloom.
So, if we're talking about atopic dermatitis, it changes over the course of a person's life. So, in infants, it can show up on the face, scalp, hands, feet. And then children, typically, we see it inside the elbows and knees on these
Mhm.
flexural surfaces. The front of the neck is a big one. In adults, a lot of time we'll see it in like the wrist, ankles, eyelid dermatitis is really common, and other flexural
Seeing that a
surfaces.
lot right now. Yeah.
Yeah. Again, why these flares continue happening in this area of tissue could be because, like, again, I don't think it's very known specifically, but could also be because these areas are just a little bit more delicate and prone to that, right? So if we like look at our wrists or, the inside, the flexural surfaces, they tend to be a little bit softer than like our elbows, for example. That's where we would typically see like psoriasis and things like that. But dermatitis can happen anywhere. So
Mhm.
it's hard to say it will happen in this exact spot all the time. So it really, really varies. And like we see dyshydrotic eczema happen on the hands and the feet a lot. So it varies a lot.
So then, umbrella terms, we love to hate them, hate to love them. How does someone know then if they've been accurately diagnosed, right? Like they're accurately put in that umbrella. How do they know that information?
I mean, for a patient, like it's hard to know because there's so much information out there. You go to a provider and they diagnose you. Usually they'll be like, yep, you just have some sort of eczema. If you're lucky, but again, lucky, unlucky, you get sent to a dermatologist. And the reason I say unlucky is like if your eczema is so severe that you're sent to a dermatologist, like again, unlucky to have that eczema, but lucky to get the care of someone like a dermatologist, right? Who is just more of an expert than like a family physician, for example. So that was a very long-winded way of saying, like, most of the time people will just be like, yep, you have eczema, not the specific type. But usually you can look out for, if you're interested, look out for like characteristic patterns. Like I said, the dyshydratic eczema will show up as little blisters. The nummular discoid eczema will show up as almost like little disc or like coin shapes, things like that. If you've had it since childhood and you also have like asthma and allergies, more likely to be atopic dermatitis. So will the patient know if they're diagnosed accurately? Hard to say. Usually people just say, yep, I have eczema, and that's the end of it.
And then it goes from there.
Yeah.
So one of the things I know we talk about internally is using some of these different kind of diagnostic systems. So can you walk us through how those are used? Because you're right. And I think this is the world of AI, right? And things are evolving and changing. You can take a picture of something, put it in, and it can give you what we call DDXs or differential diagnoses. But I do see eczemas very overdiagnosed or incompletely diagnosed. To your point, it's like, yes, it's eczema, but there's a secondary infection. Or yes, it's eczema, but there are bigger fish to fry here in terms of how we navigate it, treat it, etc. So when someone is looking at, has this been appropriately worked up, thought through, how do you navigate that? Like, we're looking at SCORAD, we're looking at some of these different things. But if someone's sitting there at home in this moment being like, okay, what are the different things I need to think about in terms of if I'm getting appropriate care, or if I'm stuck going to a walk-in clinic, right? How do I even start to describe these things, how they've changed over time, etc.? Because a lot of people don't have family docs anymore, right?
Yeah, that's very true. For that, honestly, like, I don't love to get people to like try to like self-diagnose themselves, because like skin is one of, in my opinion, one of the hardest things to treat because it is so variable and there are so many things that you can do. I will answer this question by kind of giving you my approach to things, and maybe again for those at home listening, something to think about, and have this information ready in advance to a provider if you do choose to see one. So when someone comes into my office and, like, let's say their main concern is eczema, I don't typically go, oh yeah, this is 100% eczema. I am just going to ignore the entire history and, talk about things that we can do. I don't think that's very helpful a lot of the time. And like you said, very overdiagnosed in such a broad term. So the way that I approach things, I almost like systematically have this little checklist. So I ask, when did it first start? If it started in childhood, again, more, and in those areas that we discussed that typically happen in adults, I'm like, okay, likely to be atopic dermatitis. If they say, oh, it started when I started with this new job, I work with a lot of chemicals and things like that, I say, okay, that's likely to be like a contact dermatitis type picture. So definitely looking at when it started, seeing if there are any associated symptoms too. Again, like any allergies coming up, anything new they've introduced. The location is really important as well. Like, is it on the hands? Is it on the feet? Is it on these flexural surfaces? What makes it better? What makes it worse? Those are big ones. Most of the time people will either like, no, yes, this is exactly what makes it worse, or they'll be like, I don't know. Or like, I've tried everything, but nothing has made it worse. My question is, what is everything, right? Because that's such a broad term. And even if someone has tried like my main things that I typically use for this, I will go into like, did you use it correctly? And I hate asking that because I feel like sometimes it can feel like a minimizing question, but it's not. That's just us doing our due diligence and saying, okay, did you kind of follow these steps? So it's like a nice once over. I always get a baseline of where people are at too. Like you said, like the SCORAD, is it mild? Is it moderate? Is it severe eczema? And from there, that can also tailor a treatment. People can also do the POEM assessment. And this is like basically a self-reported questionnaire. And it talks about like nighttime itching. Is there insomnia? Has it impacted your mood? And it talks about like, over the last recent while, how many times have you been experiencing this? And then other important questions to ask is like, is there a history of infections and things like that? Do you know any of your triggers? So, and then also asking topical routine as well. So we touched on this earlier, laundry detergents, moisturizers. Are you even moisturizing in the first place? Because
Yeah.
we know that moisturization is the mainstay of eczema treatment, right? Whatever the type is. And then I go into like what they've tried. So having a kind of list of that is really helpful to bring into a provider, just so you say, hey, this is the history of my condition, and this is what I've tried too, and then you can kind of go from there.
Today's episode is brought to you by none other than Advanced Women's Health. If you are interested in diving in deeper to your health, if you are finally ready to feel like yourself, and you are finally over hearing everything's normal, everything's fine, and you want a deeper dive into your healthcare, then we are here to help you. We are currently helping patients in British Columbia and Ontario, Canada. But don't worry, if you're in another province, still reach out, get added to the wait list as we expand coast to coast. We cannot wait to work with you. Check out the show notes for more information on how to get started.
So what are the most common things? Because that was the first thing I thought of when you're going through is you're like, have you done it properly? Because I know you're right. Like it's a question that, depending on the person, hits different. But what are examples of things that people are doing that in theory should work, but don't because of how they do them? Because I think it is such a key piece. And when we're talking to patients, you're like, it is overwhelming to sit there and be like, I have tried everything. And so what are some of those big things that you're like, that in theory, yes, but because you used it this way wouldn't have worked?
Oh, the biggest ones are corticosteroids, for sure. Number one, it seems like everybody and their mother are afraid to use corticosteroids these days. And also, they're not using them properly too, right? So, again, corticosteroid, very safe, lots of data on them. You just have to know how to use them properly and use enough of them too. So, there's lots of resources online, or you can talk to your provider about specifically like fingertip units that you can use.
Corticosteroid. Let's start there.
So a corticosteroid is basically a medication that helps kind of calm the inflammation on the skin surface. So it can be very, very helpful, and we'll get into like an eczema action plan later on, but it can be helpful to kind of pump the brakes on this fire that is essentially going on in the skin when we have a flare. So it is very helpful in that regard, because sometimes we do just need to pump the brakes. And like I said, people are scared because they're seeing online, like, topical steroid withdrawal with long-term use, or they're also seeing like, oh, it thins your skin and things like that. But, if it's prescribed correctly, used appropriately, then we have such a low risk of that happening, right? So when I say prescribed correctly, I mean the type of steroid used, right? So you have different types of strengths that we want to use on different parts of our body. So like if you're on your hands, for example, we'd want to use a stronger one. But if it's somewhere like on the eyelid or a more sensitive area, you would want to use a weaker one, just because this tissue is sensitive. So again, that's a piece of it. And also like duration of use and how to use it properly. So I find that there is such a lack of education on that. And, when I come into the office, it's oftentimes like, if someone's having a flare, that's like one of the main things that we'll talk about, the proper use of corticosteroids. And sometimes, patients are a little bit surprised when a naturopathic physician recommends the use of corticosteroids. But like I said, there's this fire going on in the skin surface. So one of our jobs is to actually educate properly. Hey, this is how you use this medication. It is very cost effective. There's other not like steroid sparing agents that we use, but those are more expensive. And if the patient wants to use that, of course, we'll kind of dive into that. I think patient autonomy is very important in that sense. But yeah, the proper use of them, because when people are getting these things like topical steroid withdrawal, they're typically using large amounts of the wrong steroid incorrectly. And sometimes people use them for cosmetic purposes as well. Like they're just getting like an acne lesion, for example, putting a little bit of steroid to reduce inflammation. in those cases, it's more common for someone to get a topical steroid withdrawal rather than, someone with eczema using it correctly.
So what is correctly? Like how, on average, are we talking this person should use it 3 times a day for 3 months? Like what is that general thought process that you're using it with?
My general thought process is apply the appropriate amount. So we can talk about fingertip units there. Basically, depending on how much of the skin is affected, you would use that amount. So again, you have to use the appropriate amount. And then I usually say, okay, we can use this medication for 7 to 14 days. And I want you back in about a week. I want to see how things are going. If it's not getting better in that 7 days, I ask, again, how the use is. Number 2, if you're using it correctly and it's not getting better, there's something else that we should try. Because it shouldn't always be like, okay, just use this for the rest of your life. You should use it when the flares are happening, right? That's the way it's meant to be used. And like I said, people are oftentimes just prescribed this and say, here, just use this, and then no further information there. And that's why people are scared, I think, because they read online of people using them incorrectly and getting these terrible side effects.
Yeah, and I think the fire analogy is helpful, right? Because when I'm talking to patients about the use of any kind of pharmaceutical to put out a fire, you're not going to take like little buckets like my kid's pail and throw it and expect it to work. Right? You're going to like do 3 or 4 buckets. You're like, oh, it didn't work. That's like, again, using it for 2 or 3 days, small amounts, and be like, oh, it didn't work. And the alternative is you're not going to stand there with a fire hose for days on end. Like you're not just going to be like, oh, the fire's out. Let's keep going. Let's keep going. Let's keep going. And I have patients who have been on multiple times a day corticosteroid use on large areas of their body for years. Like, yes, that's a problem because it doesn't make any logical sense. And I think that's always what I say is like, I use analogies a lot because I'm like, does it feel logical if there's a forest fire to throw a bucket of water? No. Does it feel logical to continue to hose when the flames are gone? No. So we have to think about our body in that way as well. But for some reason, I think like authority complex is something we can get into another day. But some people like balk against it and they're like, no, I'm going to use it the tiniest amount to the point it's not effective. Or I'm going to just use it forever because a doctor told me it was a good idea. And both of those things, you just like don't make any logical sense.
Yeah. I find I do that a lot, just like educating on why it's important and, like I said, the proper way to use that, because I think that is kind of like that missing puzzle piece a lot of the time. But yeah, definitely you don't want to throw a little tiny bucket on a forest fire. We kind of had to come up with what I mentioned earlier, and it's that eczema action plan, right? So what do you do when it's flaring? And then once better, how do you maintain it? Because those are the main goals. Get clear, keep clear, and then continue that.
So we hear a lot about food, we hear about the gut microbiome, all that kind of stuff. So how does that play into the understanding of eczema?
Yeah, so in terms of microbiome, and you probably heard me talk about this with acne too, but people with eczema have a different, essentially, composition of gut bacteria, number one, but also bacteria on the skin surface. So we know that we have this dysfunction in barrier integrity. So we don't only have that on the skin surface, but we actually can have that in the guts too. So that's a fancy way of saying there's a presence of this intestinal permeability. So as we know, the immune system is in our gut is sampling things constantly. And when we have someone with eczema, kind of when they're having things that will trigger them, for example, they might set off a more hyperactive immune response and get these flares or like not feel well and things like that than someone that doesn't have those things would. So that's a piece there.
And so you mean like a food, an environment, a bacteria, like what exactly are some of those triggers that happen at the level of the gut?
So yeah, food is a big one for some people. So in terms of what I see clinically and what's in the literature, The evidence of like, does food impact eczema? It's very sparse, I would say, and correlational at best. But clinically, I do see that patients have like specific things that where they're like, oh yeah, when I eat this, my skin explodes. A big one could be like sugar, for example, is a huge one, which could kind of hit off that insulin pathway again. And we know that can cause inflammation too. And then what else? For some people, actually, eggs are a big one, and low fiber diets as well. So
Interesting.
yeah, low fiber diets are a big one too. So I think we find that when we have less microbial diversity in the gut, we can have more flares. But again, with the low fiber diet, that could also be correlated with, hey, person doesn't eat that much fruits and veggies and things like that. So they're not getting these nutrients and antioxidants and all those other things that we would see benefit us at an overall level.
So the main kind of mechanism through the gut is that those bacteria and the shift in bacteria, the shift in leaky gut, as you'll hear online, but permeability is just again heightening that immune response. So it's
Exactly.
not necessarily about an individual food, an individual bacteria, etc. It's more just about the fact that it's priming the environment to have a bigger response to small triggers.
Exactly, exactly. And I know a lot of times, like if you've had eczema, you've probably tried like an elimination diet type thing. I don't think there's excellent like evidence for that. I think if you know you have a trigger and
Yeah.
it's a very obvious trigger, of course, don't have that a lot. But when we eliminate so many foods, we actually introduce the risk of developing an allergy to those foods as well in the
Mhm.
future, right? So having a little bit of these things, like a little bit of egg, again, unless you're anaphylactic, of course, but having a
Yeah.
little bit of egg, having like a little bit of dairy once in a while can be helpful to prevent these things from having a severe reaction in the future.
So, from your perspective, it's not about complete elimination of things. It's about looking at why the immune status is so heightened in the first place.
Exactly. I think
Yeah.
there was a saying, it's through the skin allergies begin, through the diet allergies stay quiet.
So, meaning what touches your skin has a bigger impact than what goes in your mouth. But what goes in your mouth is kind of like setting the stage for the magnitude of the response.
I don't know if that was 100% what they meant. I didn't make this quote, but
Yeah.
yeah, I guess that would be a very good way of putting it.
Yeah, because I think it's true. Like, what I find when I'm chatting with patients who have eczema is it can feel really overwhelming.
Yeah.
Because if you have bloating or constipation, etc., then there's the thought process, okay, I am sensitive to my stress response, I'm sensitive to the bacteria that are in my gut, I'm sensitive to food. But when it comes to topical things, it's like the weather, the sun, your products, the
Yeah.
like the type of soap that's available in the bathroom at I don't know, the mall, plus the soap that you have in your house. Like it seems like there's everything needs to be controlled and it feels really, really overwhelming. And that's a conversation that I always try to have with people is I'm like, listen, there are the things we can control and work on your gut, the overall status of inflammation, barrier function, XYZ, right? But we need to build a certain level of resilience so you're not over responding to cold, hot, sun, this and that. And so how do you have that conversation? Because I would say that's probably one of the most overwhelming things I feel people come in with is they're just like, I don't know, it could be literally anything. Yes, I have these known triggers, but there's also this huge spectrum of what I don't know that just overwhelms me so much.
Yeah. So the way that I approach that, and pretty much with all my patients, we talk about like supporting overall health in general, like making sure they're getting enough sleep, making sure they're getting enough protein, fiber, eating well, and just focus nervous system support, focusing on those
Mhm.
pillars of health. I like to discuss the five pillars of eczema too. So,
Mhm.
barrier, like we talked about, psyche, which is the nervous system response, because we do know that emotional triggers can be very impactful and cause flares too, right? Controlling inflammation, both, again, external, internal too. Like we touched on insulin earlier. So if you're having a whole bunch of sugary food and you're insulin resistant, that can kick things off to a huge extent. And then talking about the microbiome, both topical and within the gut, and also controlling itch. So those are kind of the things we go in there.
Okay, so we got this kind of framework then of the pillars when it comes to eczema. But how do you put that together into an action plan that just helps someone sort through that overwhelm?
Yeah, totally. So all of the time, patients are going to do their best to eat healthy, exercise, sleep, all of the things. When they get a flare, again, you put blank your choice of treatment to reduce that sort of fire that we were talking about, whether it's a steroid, whether it's one of the steroid sparing agents, so commonly known as like Elidel or Protopic, things like that. And then how often to use that, and then other things that are really helpful for it. Also, wet wraps for the kiddos and for adults are really helpful. So basically, if it's a kid, you can take a pair of onesies, PJs, gloves, socks, soak those in warm water, wring them out until slightly damp, and then you would put the damp clothes on and then a dry layer over top of the wet layer, and then make sure that the room is warm enough to sleep at night. So that is a great way to kind of help.
Like to keep moisture in?
Exactly. And
my kids would never. Yeah, I'm just laughing because Aiden will literally get like water on here from brushing his teeth before bed, and it's like a full clothing change, like full outfit change.
oh yeah, I know it's a bit of a normal one, but wet wraps are excellent.
Do you just a focal area? Like, could you just wrap if it's just in one spot and then put them to bed that way?
Totally. So what you can do there is, let's say you have like, if it's a kiddo and then they just have an area here, or I guess an adult too, but take a pair of socks you don't like, just cut the little toe part out, wet that in warm water, put it out over your arm here, and then put like the other set of the sock on, and then you get like a mini wet wrap. And then the use of emollients are also so helpful too. So again, in this, I know I'm going off on a bit of a tangent, but in this flare stage too, it's also so important to keep the area moisturized. So you're going to be doing your thing that's going to help control the fire and also going to continue moisturizing. When that flare has settled, you'll move on and do the maintenance phase. So in the maintenance phase, again, we're moisturizing. And in the evenings, we're also, before bed, we're doing like an emollient on top of our moisturizer. So
what's an example of an emollient?
Okay, so basically like Vaseline, Aquaphor, those like jelly type substances. I know people don't love Vaseline, but again,
you and Mary Ellen and your love of Vaseline.
It works so well because it's essentially preventing this transepidermal water loss, right? We're putting this little blanket over the part of the body that we want to keep nice and hydrated. So that's a piece there. And I know like people hate doing that. So, but I say just try it as an experiment. If it doesn't work for you, you don't have to do it anymore. Other things that can be helpful too, both in the flare and like if it's like a mini flare, for example, but black tea compresses have good evidence. So basically you would brew a tea bag, essentially let it cool down, soak gauze and apply 15-20 minutes and then put moisturizer on after. And topical B12 is actually because it's helpful too, right? It inhibits nitric oxide synthase, which can help prevent flares. And I think there was a study that looked at using it twice a day for 12 or 8 weeks and noticed significant improvement. So lots of things there we can use. There was a dermatologist that was talking at a conference, and he uses this a lot in kiddos, and he calls it the pink magic cream. So I think that's Dr. Peter Leo, and he is excellent. But that's always a little fun trick that I use.
Do you mix it yourself, or do you get it compounded?
Oh, no. You get it compounded.
Yeah.
And I can't go a day without mentioning this, but you know what I'm going to say here. Zinc cream. Zinc cream, also a really good barrier support.
I feel like we need Burt's Bees to just like sponsor this episode because girl loves a zinc oxide cream.
Yeah. But yeah, lots of things you can do there. But the biggest thing, again, coming up with that action plan. And, if you're a provider and you're wanting to come up with something for your patient, again, literally have 2 columns: what to do when you're flared, what to
Yeah.
do when it's better. So it's going to be treatment, maintenance, treatment, maintenance.
So that covers a lot of topical stuff and super actionable things. Cause like I've had patients do that where they just put the black tea bags over their eyes for eye eczema. And it can be like, it can help so much so quickly. But what does that look like as part of an overall treatment? So if we're not just looking at topicals, what are some of the other kind of 2 or 3 key areas that you're looking at systemically in terms of assessing and treating the whole body?
Systemically, I love, well, for filaggrin, L-histidine, good evidence there. Omega-3s at a higher dose. Number 1, to help support, to reduce inflammation. Number 2, to help maintain good barrier, so omegas. Vitamin D, and like treating it to sufficiency. Supporting iron as well, so making sure those nutrients. Again, this comes down to like supporting overall health and things like that too. And then when someone's also recovering from a flare and you notice that, maybe they're not healing as fast as we want them to, doing like an ACEs and zinc can be helpful too, because we're essentially giving someone those building blocks of like collagen synthesis and things like that, and antioxidants.
Yeah. Yeah. So again, really just focusing in on the immune system as the cause. And I say this over and over again because as much as we hear dermatitis and flares, and as docs, we immediately go to what's the source of inflammation. I don't necessarily think that always carries through to how patients think about it. They don't necessarily identify that the redness and itchiness on their skin could be a reflection of brain inflammation and gut inflammation and joint inflammation and some of these other things. And I think that's why we always make the flippant comment of, well, your skin's just a reflection of the rest of your body, right? It's a mirror to the rest of your health. But I really do think it's important that people take that on. If you are experiencing fatigue and you also have eczema, chances are there's a relationship. If you're experiencing mood changes, anxiety, depression, chances are there's a relationship. And I can't tell you how many times I've had patients come in and they're like, well, no, I'm anxious or depressed because of my flare. And I'm like, or did it start before? Yes, I understand that, especially depending on where the eczema is, it's overwhelming and it's anxiety provoking. But did that anxiety depression response come before the eczema? Are they related? Like it's looking at the skin as a reflection of so many other pieces. And I think that's the big difference. Because yeah, anyone can play whack-a-mole with hydrocortisone. You know what I mean? Well, I guess in some ways it is hard because if you're not using it appropriately, but it's not the integrated approach that I think so many of us value. It's like, yes, let's treat the symptom. Let's get the eczema under control. Let's get the symptoms under control. But then also fundamentally, how can we use this as an educational moment or an opportunity to expand someone's awareness around some of the other symptoms that they have and how those things could be related?
100%. And, that's why a lot of people come see us, is for that integrative approach. And someone might come see you just for their skin, but might open up a whole host of other things, right? Like I've had so many people come to see me for a specific skin thing, and then we get into the mental emotional side of things, and they say, hey, I actually have like pretty bad anxiety that, I haven't really talked to anyone about before. So they're coming to you in such kind of like a vulnerable state, and then opening up other things too. And it would be essentially a disservice if you didn't address those as well. Like, it's not like someone's coming to me with their skin stuff, and if they mention the mental emotional piece, I'm not going to be like, sorry, you just came for your skin, here's your topical, bye. But we address things from a sense of like, hey, let's look at everything, make sure you're all good. We're going to treat you with your goals in mind, but we're going to keep these other things in the back of our mind too, because they are so fundamentally important to your overall health and who you are as a person, right?
Yeah. So to wrap up, I would love to know, what are your top 3 tips for the itching piece? Because I know we talk about that a lot on clinical rounds, whether that is with adults or kids. It's like they need to stop itching. They need to stop itching. And that can feel like one of the most challenging parts of all of it. So what would you say your top tips are for that? And then I will set you free into the world.
Well, itching at night, melatonin has great evidence for that and works very well. Orally.
Orally. Okay.
Yep.
Yes.
And then what else? Again, moisturization is another big one. That's a very obvious one. And then what else? Oh, acupuncture and acupressure actually work excellent for itch too. So
Okay.
those kinds of things. Those are like, I would say like my top 3 things. But again, like obviously treating what's causing it, the itch is going to be important. But if we're looking at it through that lens, I would say those are the most important. Those are my
And do
favorite.
you have a favorite moisturizer? I know we heard your favorite emollient.
Favorite moisturizer? No, I don't. And because I think that so many people are so different into what they respond to. So if someone has a moisturizer that they like and that I approve of, right? Like no fragrance, things like that, they're tolerating it well, I'd say continue using that. I'm not biased towards any like certain brand, but I would definitely say if you're trying to find one, I think like the Eczema Society has a website where they list their approved moisturizers too. So that's something that you can browse and kind of look at.
Perfect. We'll put that link in the show notes. That's awesome. Well, thank you, Dr. Dasha. Always a pleasure having you. For anyone in BC, if you are experiencing skin concerns, Dash can see you virtually or in person at our Vancouver office. We have so many skin pictures that come in. So people always ask, well, how do you do it through virtual? But the reality is most of the time, someone doesn't come into our office in a flare, right? They're coming into our office a day after, 3 days after, 5 days after, weeks after. And you have to get photos anyways as part of the progress. You're going to have to take photos. I always recommend, I don't know if you do, as part of the treatment, because every skin issue feels like a huge issue. Whereas if you take photos of it once a week and you see there's progress, it's easier to kind of identify. So that's how we navigate, right? You're always having to document things. And now with the phones that we have and the lightings we have and all these things, it can be really easy to support people virtually. So yeah, any last parting words for those experiencing eczema who are just looking for some hope?
Don't give up. I think that's a big one. Don't let it discourage you. And if you are struggling and feel like you've done everything, you cannot, like, I would definitely seek out like professional help in someone that is kind of well versed in skin and can also give you a nice holistic approach. I find that's always helpful. Yeah, those are my takeaways, I would say. Yeah. And then moisturize. Don't forget to moisturize.
Yes, exactly. Awesome. Well, thank you so much. And we will hear from you again very soon.
Thank you so much for listening. I hope that you had as much fun as we did. And if you loved today's episode, share it with a friend and leave us a review. That is how we spread this message, and that is how we are going to revolutionize healthcare in Canada for women. Have a beautiful day and be well.